Hello everyone, I'm Dr. Linga. We'll be learning about pediatrics today. Um, Similar to adults, pediatric also has the same principle of ABC, but with slight variation. I'll be looking into each of this in the upcoming slides. Okay, when it comes to airway, if the patient is crying and speaking without any added sounds, that means there's no obstruction. And if they have stridor or gurgling from can be from any blood or their own saliva if they're semi-conscious, means the patient the airway is partially obstructed, or if they're not crying and then there's no air movements, that means a complete obstruction. Sometimes body position also gives us a clue about patient's airway and breathing status. When you see a patient looking up, neck extended and breathing heavily, they might have issues with their airway, upper and lower airway. You can see this gentleman supporting his neck accessory muscle to breathe. This tells you that he is in respiratory distress. Okay. First, we'll look at stridor. Um, this is how the stridor sounds. Okay, I'm gonna pass this now. Stridor can be acute and life-threatening, or it can be subacute, or it can be chronic. Okay, so when it comes to acute and life-threatening, anaphylaxis, epiglottitis, and foreign body, these are most likely causes, um, but relatively rare. When you see subacute, it's mostly due to croup, or it can be due to retropharyngeal abscess. Croup is commonly seen in our ED and is managed in our ED. Um, Anaphylaxis, epiglottitis, foreign body causing stridor should all be managed in P1. Okay, and there are some causes of chronic causes of stridor, which is laryngomalacia and tracheomalacia. Um, these patients with pre-existing chronic condition can present to ED when the condition is exacerbated when they have simple URTIs. Okay, all right. First, we'll look at anaphylaxis. Um, Anaphylaxis, by definition, should have two or more signs or symptoms of the listed below here: skin and mucosal involvement, respiratory compromise, hypotension, and GI cramp or vomiting. GI cramps and vomiting is easily dismissed as one of the systems affected. If you look at the picture here, the child does look unwell, but if you see without your examination, only the skin and mucosal system is involved, which is just one system. Okay, treatment for anaphylaxis is IM adrenaline. Dosage is 0.01 ml per kg of 1 is to 1000, which is a neat undiluted adrenaline and which can be repeated every 10 minutes, and it's given in the anterior lateral thigh. Okay. This dosage calculation can be quite tricky, especially in a when you're managing a very unwell pediatric child and it's very chaotic. Okay, this guidance is from United Kingdom Medical Council. They divide the doses of adrenaline according to patient's age, and is easy to remember. And you can use this as a rough guide to quickly calculate the adrenaline dose needed. For less than 6 years is 0.15 ml, or 6 to 12 years is zero point 0.3, and more than 12 is treated as adults. But this sometimes can under or overestimate the dose of adrenaline because it is not weight based, it's age based. So it's always better to calculate the weight based formula, but in the event the adrenaline has to be given quite rapidly, or you forgot, you can use this prefixed dosage. Okay, next is foreign body. It's very common in 1 to 3 year old child. It can happen in less than 1 year also. The siblings can put things in the mouth when they are playing. Usually, it is a sudden onset symptom in a previously very well patient. They'll be uh, they'll be well until the last minute when they develop symptoms. If the foreign body is in the laryngotracheal area, it can cause stridor. If the foreign body goes further down and blocks the bronchus, it can present with wheeze as well. Okay. Next is epiglottitis. It's a very rare condition now because of vaccination, and it's a very severe illness. If you suspect epiglottitis, these patients should be uh, managed in resus. Okay, they usually present with fever, very high fever. The child looks unwell. They can have drooling because they're not able to swallow their saliva because it's painful. They could have sore throat. It's also is very rapidly progressive. The child might be well in the morning, and suddenly in the afternoon they are very unwell. They will be in tripod position. They might be in tripod position, and there might be no cough. Okay, this condition is mainly managed by anesthesiologist and ENT. If requires intubation, the patient should be intubated in the OT with inhalation anesthesia. Okay, next is croup. As I said earlier, it's a very common on our ED, and this can be managed in a PEDS treatment area. Croup is basically viral laryngotracheobronchitis, which means it affects the larynx, the trachea, and the bronchus. So it can give stridor because it affects the larynx, the trachea, and bronchus. It can present with wheeze, so it can have wheeze and stridor together. Okay, it commonly affects 6 months to 3 years old child. They usually have hoarse voice, cough, fever. Symptoms are usually worse at night. Treatment is steroids in any forms. Severe cases of croup will require epinephrine nebulization. Okay. Yeah. Croup is a clinical diagnosis. You don't need an X-ray. You don't need an X-ray to make diagnosis of croup. But if you suspect a foreign body and then you do an X-ray and then you see this typical steeple sign where you see narrowing of this opening, it could suggest croup. Okay. All right. So to assess the severity of croup, there's a scoring system which can help you, which is called Wesley Croup score. You don't actually need to remember all the components or all the scoring, but whenever you see a patient with croup, it is better to score the patient to guide the treatment and disposition. Okay. So this here is mild croup, and this is moderate, and this is severe. You can see the dexamethasone dosage is different in mild and moderate patients, and adrenaline only comes in when the score is 4 or more. Okay. Next is a retropharyngeal abscess. Again, is a very uncommon condition, but because patients present early in the illness, this is usually complication of untreated pharyngitis or any oral or pharyngeal infection. If it's untreated, it can develop into retropharyngeal abscess. Again, it's very uncommon because patients tend to present early to us. Okay, if they can present with neck pain, swelling, spasm. They can also have drooling, dysphagia, stridor, and fever. This is because the retropharyngeal space is close to the airway and it's very tight. If there's any collections here, it can push the airway forward, causing obstruction of the upper airway. Okay. Again, if you suspect retropharyngeal abscess, the patient is very unwell. This patient should be managed in resus, and treatment is usually antibiotics, INT if needed. Okay, so now we know what are the conditions which can affect pediatric airway. Now we will look into the management of airway itself. Okay, if you look at the picture here, you will see a few things different from adult airway management. You can see the laryngoscopist is compressing the cricoid with his little finger, which might not be possible to be done in adult patient, mainly because of the size. And if you look at the laryngoscope itself, it's not a curve, it's a straight blade, and they don't have anything under the occiput to position for laryngoscopy. Okay. This picture tells you a difference between child and adult airway. It actually starts with your nose. Uh, Pediatric patients are obligate nasal breathers. Very young ones really haven't learned how to breathe through their mouth if the nose is blocked. So any amount of blockage of the nose or any congestion in the nose can make them really tachypneic and put them in significant respiratory distress. They can only cry, which can partially compensate for the blocked nose. Uh, but unless the nose block is relieved, they will still be continue to be tachypneic. Okay, then we come down, we look at the tongue. Tongue is relatively larger in the oral when compared to the oral cavity of the oral cavity, and further down the epiglottis is very large and floppy. That's why a straight blade need to be used to lift up the epiglottis, because in adults, if we put our laryngoscope at the base of the tongue and we lift, the epiglottis will be lifted together. But in pediatrics, because it's very large and floppy, even if we put the laryngoscope in the vallecula and lift, you might not be able to visualize the cords. Okay, yeah. And when you go further down, in adults, the narrowest part of the airway is the vocal cords, but in pediatrics, the narrowest part is the subglottic area. Okay, that is why it is acceptable to use an uncuffed tube, because that's where the subglottic area is where the ETT sits in. Okay, and further down the lower airways, the children have less functional residual capacity. Okay, so it means that they can easily become hypoxic when if you're not able to intubate them at your first attempt. Okay, this picture shows you how to position and optimize your laryngoscopic view. So if you look at the first picture, without any manipulation of the head and neck or positioning, if you open patient's mouth, you will be only able to see the back of the throat. So if you see after positioning and flexion extension of the neck, you will be able to achieve a good view of the glottis. Okay, so to achieve a good view of glottis, in child, we can use different techniques, right? In an infant, we can put a rolled up towel or some kind of a wedge under the patient's shoulder, um, and that can improve the laryngoscope view. You don't need to put anything under the patient's head because their occiput is larger to begin with. Okay, what we are trying to achieve here is um, the imaginary line intersecting the anterior shoulder and the ear should be straight. Okay, so if you make sure that anterior shoulder line intersects with the ear, when you put in your laryngoscope, you can easily will be able to visualize the cords. Okay, in small child, you don't need any support. You just need extension at the occipital joint. Okay, and in older child and adults, you need to put a donut under to help you to better optimize the view for laryngoscopy. Okay, and now we know how to position, and we need to learn about what equipment to use. Okay, um, in ETT, size and length is we don't bother much in the adults because it's standardized to 7.5 in female and 8 in male, but children come in different sizes, so you need to know different what size to use exactly. Okay, in a newborn, until 1 year, um, unfortunately there's no set formula. You just need to remember, or you can always use the bossless tape which is available in our research room. You can always refer to the bossless tape if you have any doubts on what equipment to use, and what size of equipment to use, and what dosage of drug is needed. Okay, so for a newborn, we can use anywhere from size 3.5 to 4, depending on their estimated weight. Okay, if they're more than 1 year, we can actually use this formula to help you determine what is the required size for the patient. Okay, if it is an uncuffed tube, the formula is H divided by 4 plus 4. Okay, and if you want to use a cuff tube, the formula is H divided by 4 plus 3.5. Okay, it can only be used in a patient who is 1 year and older. All right. Okay, so let's see. Okay, uncuffed tubes are used actually to prevent pressure necrosis of the subglottic area. You remember I told you the nervous part of the pediatric airway is the subglottic area, and that's where the ETT sits in. Okay, because it's already narrow to begin with. If you use a cuff to put more pressure on it, it can cause pressure necrosis. Okay, but recent studies have shown that cuffed is as safe as uncuffed. Okay, and there are innovative tubes where they use low pressure high volume tube, meaning that you can use very little pressure but you can get an adequate seal of the subglottic area. Because one of the major drawback of an uncuffed tube is it can cause a lot of leaks, and you might not be able to get an adequate tidal volume. Okay, and our ED, the smallest cuff tube you can use is 5 mm. If you want to use cuff tube for 4, you can't. It's the smallest we have is 5 mm. Okay, from 5 mm onwards we can choose to use cuff tube. Okay, that is all for airway. Okay, let's look at respiration now. um, Respiratory problem. Okay, there can be distress, or there can be respiratory failure, or there can be respiratory arrest. Okay, how to identify? Okay, so identifying respiratory distress, okay, you can identify by looking at patient's speech or cry. If the speech is um, um, there's no continuous sentence forming, or it's the speech is just one words, and then they're stopping to breathe in air, that also tells you that they are in respiratory distress. And also same thing goes for the crying. If they stop in the middle of the cry to take in deep breath, and if it occurs more frequently than normal, then again that tells you that patient is in respiratory distress. And as I said earlier, position, like tripoding, kneeling down, all tells you the patient is in respiratory distress. And you can look at the chest movement and the muscle retractions. Okay, I'll shortly come to where to look for the muscle retractions. And nasoflaring, it's a very unique thing into pediatrics. As I said earlier, they are obligate nasal breathers. So when they are in respiratory distress, they try to increase the space for them to inhale. So the nasal space will increase, and is very commonly seen in very young child. Okay, who hasn't really learned to breathe through their mouth during distress. Okay, grunting, again, it's a very unique thing to pediatrics. This is due to lower, it's due to lung problem. What they essentially do is create a auto PEEP where they breathe um, against a closed glottis. Okay, so that will create a PEEP and then improve oxygenation. Okay. All right. So this is how the muscle retraction can help you um, assess how severe the distress is. Okay. Let's say the muscular retraction is in the subcostal, substernal, intercostal. It's usually mild to moderate. But if you see anything above the sternum or the clavicle, it's a very severe one. These kind of patients need to be managed in resus. Okay. Supraclavicular, suprasternal, and sternal retractions. Okay, where to look for here? Okay, so it goes from bottom up. Okay, as it goes higher, it means it's more severe. Okay, so subcostal retractions here, substernal and intercostal. If you see any retraction above clavicle or sternal retractions, the patient is in significant distress. These patients should be managed in resus. Okay, all right. How to identify failure? Okay, so far with the distress, they might be still be able to maintain adequate saturation and mentation, right? So if they became hypoxic or they drowsy, that should trigger you to think about respiratory failure, either be it's oxygenation or carbon dioxide ventilation. Okay, okay, and next thing is not all V's is asthma. Okay, because anaphylaxis can cause V's. Foreign body, as I said, it blocks the bronchus, can cause V's. That is one of the reasons we would do an X-ray in a patient who presents with first V's. Okay, and croup can cause V's as well. Okay, so all V's is not asthma, right? So these are the conditions in pediatrics which can cause acute respiratory distress. This list is not exhaustive, so asthma, bronchiolitis, pneumonia. It can be a cardiac cause of V's. Okay, and sorry, these are the lists which causes acute respiratory distress. Which is asthma, bronchiolitis, pneumonia, cardiac cause, metabolic cause like DKA also is common, and central nervous system cause. Okay, and we'll look at a little about asthma. Okay, so asthma can be clinical diagnosis, not necessarily always they need spirometry. Okay, because some of the children they may not be cooperative for spirometry, so you might not have a spirometry diagnosis of asthma. Okay, so we can look at a few things in the history and family history, and also the patient response to certain medications to make a clinical diagnosis of asthma. Okay, patient with recurrent V's, background of atopy, like they have allergic rhinitis, eczema, the family history of asthma, and if their V's is responsive to asthma medication, then you can make a clinical diagnosis of asthma. Okay, okay, next. When to do X-ray in a patient who presents with V's. Okay, first episode of V's, it's better to do an X-ray to look for inhaled foreign body. Okay, and if you suspect foreign body, of course, and suspected pneumonia, pneumothorax, or significant the patient is not improving despite your medical management, you want to look for other causes, then do an X-ray. Okay, the X-ray here actually shows a hyperinflation of the left side, and then the right side is normal. So this is an indirect sign of inhaled foreign body. Okay, so it's hyperinflated on one side, and yeah, it's normal on here. Okay, all right. So treatment for asthma, salbutamol and ipratropium is the mainstay. Dosages are based on weight. Okay, more than 10 kg get 10-4, less than 10 kg get 5-2. Okay, and nebulized salbutamol also is varies according to the age. Okay, and when to give systemic steroids. Okay, exacerbation for more than 48 hours, past history of severe episodes, persistent asthma not responding to increased dose of inhaled steroids, and moderate to severe asthma. Okay, all of these patients need steroid. This means essentially everyone you will see in our ED coming for exacerbation might need steroids. Okay, the dosage is prednisolone 1 to 2 mg per kg, maximum is 40 mg oral, and hydrocortisone can be used in a patient who is very unwell and requiring IV. Okay, other drugs, magnesium sulfate, adrenaline, can also be used. Magnesium sulfate is in adults we have very low threshold of using magnesium sulfate, but in pediatrics it's reserved for very unwell child. Okay, adrenaline can also be used 0.01 ml per kg, can be given IM, and it's reserved for patients who are really unwell and as a rescue measure. Okay. Okay, when you're discharging asthmatic patient, okay, you need to consider giving them MDI salbutamol plus or minus steroids. I will shortly tell you when to consider giving MDI steroids, and oral steroid of course, and asthma action plan need to be filled up and given to the parents. Okay, and then adequate follow up with GP or pediatrician. So if you want to know when to give steroids, inhaled steroids. Okay, inhaled steroids. You can ask them these questions. Whether they have any daytime symptoms. You can ask these questions. If they have if they come under partially controlled or uncontrolled, you can consider adding them on inhalation steroids. Okay, the inhalation steroid typically what we start is fluticasone, 100 microgram per day. Okay. All right. So sometimes you might encounter patients who comes to you not necessarily with a very bad acute exacerbation, but it might just be poorly controlled. Okay, it's better to look at this step approach to see what is the next best step for your patient. Okay, so whenever you see a patient who is already on maintenance steroids, and they are still having symptoms, it's always better to look at this step-based approach. It's given by a lot of this asthma society, BTS, and all other asthma societies. You can get it from any one of them. Okay, next is pneumonia. Pneumonia is again one of the most frequent cause of respiratory distress. It's a clinical diagnosis most of the time. Okay, they may present with cough, fever, and tachypnea, and then you might hear a craps at only particular area of the lungs, or it can be diagnosed with X-ray as well. Okay, where you can see a patch or lobular infiltrates. Okay, so if you see a consolidative patch, most common organism is Streptococcus, and the treatment is high dose amoxicillin. Okay, if you see diffuse infiltrates, treatment is most common organism is atypicals, and treatment is macrolide. Okay, when do you admit? Okay, when do you admit patients with pneumonia? Less than 6 months old, admit. Less than 2 years with consolidation, admit, because they are high risk of empyema. And toxic looking, poor feeding regardless of the age, admit. Okay, don't send them home. And alright, that's all for breathing. Okay, we'll look at circulation now. Again, how to assess circulation? You look at the color of the baby, they're pink or they're pale, or peripheries warm, cold, and cap refill, if it's more than 3 seconds, they're shocked. Okay, cap refill is better done in the center of the body. You can use the forehead, or you can use the sternum, sternal area where there's a bromoprominence there. Nail bed can be used in a pigmented child. Okay, you need to press until it blanches and let go. All right, and count the return of color. And of course, the heart rate and blood pressure also gives us a clue on their circulation status. But be mindful that pediatric heart rate and blood pressure numbers are quite different. So whenever you see a child of certain age, it's always better to look at their the reference range for that particular age, so you can have an idea of whether the patient is tachycardic or hypotensive. Okay, all right. So here is a rough guide to quickly calculate at bedside to see whether the patient is hypotensive or not. Okay, term neonate, okay, less than 60, hypotension. Okay, less 1 year, less than 70, hypotension. So the numbers are like 60, 70, and 90. Okay, so we need a formula to remember for 1 to 10 year old. So the formula is 70 plus age times 2. Anything less than that is hypotension for them. Okay, more than 10 years we treat like adult, less than 90 is hypotension. Okay. Fluids, all right. So hypertension need to be treated with fluids. For hypovolemic and distributive shock, the recommended dosage is 20 ml per kg. It can be given over 5 to 10 minutes. And cardiogenic shock, you give lower volume and slower. Okay. DKA, again, 10 to 20 ml per kg can be given. There's no real consensus on how slow or how fast need to be given in DKA, because anticipated cerebral edema for over or rapid correction. Okay. All right. So next common presentation is dehydration. It can be from vomiting, it can be from diarrhea, it can be from not eating because of some throat pain or some ulcers in the throat. Okay, these all can cause dehydration. There are several scoring systems available. I find this one to be neat and easy to use, and the kick. So these have like general appearance of the patient, eyes of the patient, mucous membrane, and tears. Okay, so if the score is 1 to 0, there's no dehydration. 1 to 4, some dehydration, and you know, and so why do we need to know this? Is because if you can estimate the amount of dehydration, we can give them adequate fluid replacement based on that. Okay, but the best thing to know for dehydration is patient's pre-illness weight. Okay, if we know pre-illness weight, that is the best to calculate for dehydration. So if you compare and then you use the weight loss as an estimate to calculate the percentage of dehydration, that's the best you can do. It is not uncommon for them to have the pre-illness weight, because they might have gone for vaccination, or they might have gone for some growth check or what. So we will most of the time it's better to ask the parents whether they had any recent weight, so we can compare, and that can give us an idea of the a percentage of dehydration. Okay. So what's the management for dehydration? Treat the cause, of course, and replace whatever they have lost, and also you need to give them maintenance. Okay. So treating cause, of course, if there is vomiting, we can give them something to stop the vomit. Most commonly used is ondansetron. Used drug is ondansetron. Dosage is 0.1 mg per kg, given as a single oral dose. Okay, and it's not indicated in less than 6 months, and it is internationally agreed to be used for more than 6 months only. Local guidelines don't use it for less than 1 month, less than 1 year. Okay. So then the replacement, IV oral, what do you want to do? Okay, so there's no difference in outcome when it's mild or moderate dehydration. Okay, in severe dehydration, IV seems to be doing well, because it has to be slow and given slow and closely monitored. Okay, and oral actually reduces length of stay and potentially can avoid admission. And LNG tube is an alternative for IV if the patient is persistently vomiting, but it's not commonly used locally. Okay. All right. So let's say you want to give them IV hydration, and how much to give. So the replacement and the maintenance, how to calculate. So in the upcoming slides, I'll be telling you how to calculate and how to administer the replacement and maintenance drugs. Okay. So let's say you calculate the patient to be a 3% dehydration, and the patient is 10 kgs. So you simply just multiply 10 times the percentage, you will get the ml of ml of dehydration volume. Okay, so this is the replacement volume you need to give the child. Okay, and this is for IV. Okay, you remember that. Then we'll now go to the oral replacement, which is commonly done in the ED. If you think the patient is less than 3% dehydration, you can just give them trial of feeds. They don't read a replacement. They just need you just need to make sure that they'll be able to adequately take some feeds when they go home, and that'll be enough for them. If you think they are 3 to 5% dehydration, then they need 40 ml per kg fluid, oral fluid over 4 hours. Okay, and moderate is need to give 60 to 90 ml per kg over 6 hours. Okay, and if they have ongoing losses from vomiting or diarrhea, then you need to add another 10 ml per kg for every loose stool and 2 ml per kg for every vomiting. Okay. All right. So total fluid, right? So will include, as I said, your maintenance, your deficit, and also your ongoing loss. Okay. So how to calculate maintenance, right? All right. To calculate maintenance, um, for uh, for a newborn 1 day old, the maintenance is 60 ml per kg per day. Okay, this for 24 hours, and until they reach 4 days, um, you can use this table, 60, 90, 120, 150. If they are more than 28 days old, you can use a formula called 4 to 1. Okay, or 150/20. Okay, both are same. 4 to 1 is for per hour calculation, and 150/20 is per day calculation. Okay, so this is called a holiday Sager method. Okay, basically it tells you how much maintenance fluid they need. Um, so how to calculate, right? So for first 10 kg, each kg needs 100 ml. Okay, for the next 10 kg, each kg needs 50 ml. For all the rest of the kgs after 20, each kg needs 20 ml per day. Okay, but if you look at hourly requirement, it's 4 ml per kg per hour for the first 10 kg, and 2 ml per kg for the next 10, and after that is 1 ml per kg per hour. Okay, um, so now you know that how much to give and what to give, right? What fluid to give, what type of fluid to give. Neonate, we need a combination drip. This will require a lot of calculation. If you need to start a combination drip for a neonate, we'll be discussing the volume and all that uh, with the ICU team from KK. Okay, for 1 to 3 month old, we need to give 5% dextrose, but plus of normal saline. For more than 3 months, all pediatric is 5% dextrose plus normal saline. Okay, 5% dextrose plus normal saline. All right. So that's all for A, B, C. Okay. Now we'll move on to E, exposure rash. Right. So which is a very common presentation in pediatric as well. Right. Rash can be from can come with fever, or it can be from eczema. It can be from scabies, which is a parasite, and can be HSP, which is autoimmune. Okay, so we'll look at common febrile exanthems first. Okay, I'll go one by one, and then with some pictures. All right. Okay, scarlet fever. Okay, is also very common pediatric febrile exanthem. It's caused by group group A beta hemolytic streptococci. They typically have this circumoral pallor. You see, they have a rash in the face, but then the around the oral cavity is pale. Okay, and they can have white strawberry tongue or a red strawberry tongue, and they have a rash which feels like a sandpaper. If you palpate the rash, you'll feel like a sandpaper. Okay, and they might have something called pastia lines, which is actually the rash confluence in the area of armpit and the groin, and they can have desquamation, means they can have peeling of skin after a few days. Okay, if you diagnose scarlet fever, the treatment is amoxicillin. Okay. Next, very common presentation is HFMD. Okay, it's caused by enterovirus. There's a variant of HFMD wherein it's called epangina, where there's an isolated lesion in the mouth. Okay, and in less than 5 years, be careful, it can cause myocarditis or encephalitis. Okay. So if they present with HFMD and febrile seizures, uh, uh, please please warn them there's a possibility of encephalitis. All right, and treatment is mostly supportive. You need to isolate the child for 10 days. Um, uh, the most common problem with HFMD is reduced feeding, and it's very scary because the child might not eat or drink, and which can cause significant dehydration. Right. So we for this we can encourage them to drink cold fluids, or we can ask the parents to give food type of food that child really likes. So to encourage intake. Right. Next thing is slap cheek. Okay, again viral infection. Okay, uh, it's caused by parvovirus B19. They can have truncal rash. Okay, the truncal rash looks like a lace, and they can also have sycamore pallor. Okay, the rash is different. It's not sandy paper. It looks like a lacy rash, and it can precipitate aplastic crisis. Okay, make sure the patient is not very pale looking when you assess them. Again, the treatment is symptomatic, right? Okay, next is Rosella infantum, otherwise called as exanthum subitum. Also a viral infection. It is commonly seen in 6 months to 3 years of age. Um, this rash is a very interesting condition where the rash appears after the fever goes away. So you might have seen the child, like 2 or 3 days earlier for viral fever. You send them home and they come with rash, but then now the fever is gone. Okay, and if you have such presentation, we can suspect Rosella infantum, and uh, they can have prominent cervical and occipital lymphadenopathy, which is not very specific to this condition, but they can have this. Okay, right. Next common is eczema. Okay, again eczema presentation is very very common. They can come with some flare up, even with some no, normal fever and some URTI. The eczema can flare up. It's typically itch that becomes a rash. It starts as an itch, then it becomes a rash. They might say, okay, it was just itchy, then I go scratch, and then now it's rash. Treatment is moisturizer, topical steroids. So in a patient who already known to have eczema comes in with a flare, we need to make sure there's no secondary infection. Okay, because secondary infection will require additional treatment. Secondary infection can be viral or bacterial. Okay, if it's a bacterial infection, or topical or oral antibiotics based on the severity can be used. Viral infection can occur, which is a very serious illness, which is called eczema herpeticum, wherein they can have hemorrhagic blisters and punched out lesions. If you see the face of the child, it's all hemorrhaged and crusted. This is suggestive of eczema herpeticum, and they can have punched out lesion. Also, is common for eczema herpeticum. Usually, the eczema rash is not painful. If they complain of pain in an eczematic rash, significant pain in an eczematic rash, you should suspect eczema herpeticum. Okay, and treatment is antiviral, and probably they will require admission. Okay, next is scabies. Right, it's a mild infection. Um, uh, it's usually a red bumpy rash. Skin burrows, not seen all the time, and skin above the neck is typically not involved unless they are infant. And treatment is also, like, there are two different treatments based on age group. Okay, permethrin for less than 6 months, and malathion for more than 6 months. Okay, all right. Okay, next is HSP. Again, is a vasculitis. Typical age is 3 to 15 years of age. All right. The typical triad is purpuric rash in the legs and the buttocks, uh, with abdominal pain and arthritis. Means abdominal pain, joint pain, and rash. Okay, think of HSP. It can also cause renal disease. The rash is not always purpuric. It can start as urticarial or maculopapular, then it can become a purpuric rash. Okay, mm, we should make sure that there's no renal involvement, um, because hematuria, proteinuria, and then if there's edema, these kind of patients might require a follow-up, close follow-up with the pediatric medicine team. In ED, if you suspect HSP, we need to do urinalysis, make sure there's no proteinuria or hematuria, and make sure the blood pressure is normal. They can be hypertensive, which is a sign of nephritic syndrome. And treatment is usually NSAIDs and steroids. This is the only condition where gastric region pain can be treated with NSAIDs and steroids. Okay, and we'll go look at life-threatening condition with rash. Okay, the three common, not common, three need to know rashes, which is life-threatening, is Kawasaki and SSS and meningococcus. Okay, Kawasaki again is life-threatening because of its cardiac complications. It can cause cardiac aneurysms. All right, it's a vasculitis of unknown etiology. Right, if you suspect Kawasaki, admit the patient to inpatient to KK. Right, when to suspect? Okay, anyone with fever of more than 5 days, suspect Kawasaki, and look for the signs. Okay, so they can have red eyes, but the red eye is very clear, not purulent, not with purulent discharge. They can have cracked lips. They can have red strawberry tongue. They can have red swollen hands and rash involving the body. Yeah. So whenever you see a fever for more than 5 days, you need to ask yourself whether this patient could have Kawasaki or not. If have any concern, then this patient need to be admitted. Okay. Next is Staphylococcus scarlet skin and bullous scarlet skin syndrome, which is also life-threatening because it behaves like a burns. If it occurs, if it involves most of the body, then they can have secondary infections. They can have shock from volume loss from the open skin. All right. So it's a toxic mediated erythroderma. A less severe form of this is bullous empetico. Okay, wherein the bullous lesion is only in a few places of the body. If it's all over and there is peeling of the skin, we should always suspect Staphylococcus scarlet skin. And in most cases occurs in less than 6-year-old. Treat like burns and antibiotics. These patients definitely require admission. Okay, meningococcus again is not very common, but it's a very fatal illness. So you should always, whenever you see a rash with fever, you should always make sure that the patient, this is not meningococcus. Okay, they can present with just flu-like symptoms, cough, runny nose, all the way at the spectrum, and present with shock. Okay, children can just present with the limb pain, which is again apparently a very not a very uncommon presentation of meningococcus. Okay, if you suspect meningococcus, but these patients need to be observed in the hospital. Yeah, and the rash is not always petechiae. It's only 50% of the cases the rash is petechiae. Okay, if the rash involves on most of the body surface, it's called purpura fulminans. That means they are in extremes of the condition. Okay, that's all for rash. Mm, we will shortly look at what are the differences between adult and uh, pediatric cardiac arrest. Okay, what you need to do differently. Okay, so compression wise, if it's a newborn, the compression is 3:1. Okay, compression and the respiration ratio is 3:1. 3 compression, 1 breath. 3 compression, 1 breath. Until puberty is 15:2. In adults is 30:2. Right. When it comes to drugs, adrenaline, the dosage for adult is 1 mg. Um, for pediatrics is 10 micrograms per kg, which is 0.1 ml per kg of 1 is to 10,000. Okay, so in pediatrics, one vial can be used for multiple times. So um, um, when you dilute the 1 mg of adrenaline, 1 is to 1000 into 1 is to 10,000, um, and the dosage is 0.1 ml per kg. Okay, amiodarone is 5 mg per kg, and when it comes to shock, defibrillate is 4 joules per kg, and you can gradually increase up to 10 joules per kg, and cardioversion is usually 1 to 2 joules per kg. Alright, that's the end of the presentation. Thank you.